The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Thank you for joining me today to discuss the 2021 participation in the Quality Payment Program. My name is Bruce Mackey. I am the Regulatory and Incentive Program Analyst for Altarum, based out of Ann Arbor, Michigan. Today, I'll review the 2021 participation rules of the Quality Payment Program, providing general program education, as well as reviewing the notable changes in this fifth performance year. I'll discuss the participation timeline, eligibility requirements, and various reporting options, notable updates to each of the 4 performance categories, as well as changes to the 2021 performance threshold and subsequent payment adjustments. From there, I'll finish with an overview of the alternative payment models track and its effect on your program participation. All right, let's jump right in. So we're here, of course, talking about the Quality Payment Program, which has these 2 tracks to it. The MIPS track, Merit-Based Incentive Payment System, and the Advanced APMs track. Overall, the QPP came to us as part of the MACRA, the Medicare Access and CHIP Reauthorization Act of 2015. And really what it did is it repealed the sustainable growth rate formula, which was set to kind of devastate clinician Medicare payments. So really it changed the way that Medicare pays clinicians, establishes this new framework to reward clinicians for value over volume. And really it's designed to get away or transition us away from that traditional fee-for-service payment model. So again, we have these 2 tracks, the MIPS track and the Advanced APMs track. But I'd like to point out that there's almost sort of a third track that bridges the 2 of these, and it can be a little confusing, and I'm going to unpack this more as we get deeper into the slide deck. But that third track is the MIPS APMs track. It actually has components of the 2 other tracks, the MIPS track and the Advanced APM track. And again, it can be a little confusing. So I like to kind of point that out, that there's almost this third track that bridges the gap between those 2. I also want to call your attention to the website at the bottom of your screen, the www.qpp.cms.gov. That is CMS's all-inclusive, everything about QPP website. There's a ton of great resources there. It's where you check eligibility. If you are submitting data to CMS, that could be one of the ways that you're doing it as well, through the login portion of that screen. But it's a really great website, and I highly encourage you to check it out as well. So what is MIPS? Again, it's the Merit-Based Incentive Payment System. It combined several of these legacy Medicare Part B programs that we were working in for several years into a single program called MIPS. We have the quality performance category, the cost performance category, promoting interoperability performance category, and the improvement activities performance category. And really what you're doing is trying to get the best MIPS final score that you can. Each one of those 4 performance categories has a weight attached to it. Those weights have shifted from year to year. We are very close to having them be solidified, and we won't see them change anymore really after this year. But for this year, the quality performance category is worth 40% of your score, cost is worth 20%, improvement activities is worth 15%, and promoting interoperability is worth 25%. The points earned in each of those performance categories are then added together to create that MIPS final score. And then your final score gets compared to the annually set MIPS performance threshold to determine if the participant, who we call eligible clinicians or ECs in this program, or the group, receives a positive, negative, or neutral payment adjustment. And that threshold, that minimum threshold for this year, is 60 points. Here's the overall timeline for this year, and really I like to show this graphic really just to point out that there is a 2-year difference between the performance year and the payment adjustment year. So right now you are working in the 2021 performance year, and the score that you get that's compared to that MIPS final score is going to affect your 2023 Medicare Part B payments. All right, let's get into program eligibility criteria and the reporting options. Not a lot of changes here, really almost no changes whatsoever. We did not, again, see any additional eligible clinician types get added to the MIPS program. So these are the same clinician types that we have had for a number of years now. Although just note that they are proposing to add a couple of more folks to this list for next year. It's not finalized yet, so we're not going to discuss too much 2022 proposed rules, but just note that we are likely to see this list get expanded by a couple of other clinician types for next year. We also didn't see any changes to that low volume threshold for this year. So that low volume threshold is what determines whether that eligible clinician or group is included in MIPS for this year. So at the individual level, there are these three components to that low volume threshold. You have to bill more than $90,000 a year in allowed charges under the Medicare physician fee schedule, and you have to furnish covered professional services to more than 200 Medicare beneficiaries, and you have to provide more than 200 covered professional services to those Medicare beneficiaries. All three of those conditions have to be true for an individual clinician. And if they are, they will find that their participation in the program for this year is mandatory. If any one of those three conditions is not met, then the clinician's participation is not mandatory. You can check program eligibility at that link on your screen right there. And to be automatically included in MIPS, again, you must exceed all three of those. So if one of them is not true for you, then you've got some options that you could exercise for this year instead. So what happens if you are one of those where you're excluded from that mandatory participation because you did not exceed that low volume threshold at the individual level, but you might still want to participate in MIPS. There's some benefits to do so anyway. There are a couple of options for you. You can voluntarily participate. If you choose to voluntarily participate, you're going to submit your MIPS data to CMS, and they're going to score it, and you're going to receive performance feedback. But you are not taking part in any of the financial gains or losses as a function of that if you voluntarily participate. So no payment adjustments regardless of that performance. And just note that some of that program data that you voluntarily submit to CMS here will still be publicly available on the Medicare's Care Compare website. You can also opt in again this year. We've had this option for a few years now, and it remains an option for 2021. If you are one of those eligible clinician types and you meet or exceed one or two, but not all three of those low volume threshold criteria we just talked about, you may opt in to MIPS participation. If you opt in, you're going to be subject to all of the MIPS program rules and the subsequent MIPS payment adjustments. So naturally, you wouldn't want to opt in if you can't at least get above the 60-point MIPS threshold for that final score, because then you would be opting to take a penalty, and no one would do that. Once you do make that decision, you cannot reverse it for that single program year only. So just note that you want to make sure that if you are going to opt in, that you can at least exceed that payment threshold for this program year. For some additional details, I've got a link on your screen there if you grab the slides. This is a 2020 resource. CMS has not updated this yet, but none of the info has changed for 2021. Same reporting options as we've had for some time now, almost every year of this program. You can report as an individual clinician. Under that rule, each NPI and tax ID combination is seen as a separate program participant. So if the clinician is moonlighting elsewhere or has a second job under a different organization, you don't have to worry about what happens at that organization. You're only looking at the visits and the patient care and all of that at your TIN. You can also participate at the group level. A group is any two or more clinicians who have reassigned their billing rights to a single tax ID number. And in that instance, you are consolidating all of that data and submitting a single data set to CMS, and then the entire group, all of the NPIs in that group would get the same score and the same payment adjustments. APM entities. That's an alternative payment model, and I'll talk about that more. Most of the time you can think ACO when you see APM, although there are several other types of APMs as well. But if you are in any type of APM or ACO, you're going to be automatically scored at the group level. Although this year there are some changes with that and some additional options for that if you are in one of those APMs. And I'll talk about that when we get a little further into the deck and we start talking about the new APM performance pathway, or APP. It sort of opens up some options for you if you're in one of those APMs. We also still have the virtual group option, which is not very popular. We don't see too many folks forming that virtual group, but it is still an option for you this year as well. So we still get this question from time to time, although not as much, because I think folks are getting a lot more savvy in this program. But the question is, should I report at the group level or the individual level? So for a lot of MIPS participants, it's actually best to submit both ways. And the reason for that is that CMS, if they receive 2 data sets on you in one performance year, one at the individual level and one at the group level, they're going to score both of those, but then they're going to award you with the higher of those 2 scores. So with this in mind, the best overall strategy could be to always group report, unless, of course, the group score is below that minimum performance threshold. Again, that is 60 points this year. If the group cannot exceed 60 points collectively, definitely don't group report, because you're going to be opting to take a penalty. But if the group can score above that minimum threshold for the year, then it could be a good idea to go ahead and group report. And then if any of the eligible clinicians in your group are eligible to report individually, and his or her individual MIPS final score is better than that group average, also report that clinician's individual data to CMS. With that strategy, the lower performers' scores in the group are raised a little bit by that higher group average, and then the higher performers are not negatively affected by the lower performers, because CMS is going to get 2 data sets on them, and they're going to score that individual clinician with their own individual score, as opposed to that slightly lower group score. All right, let's get into the 2021 changes in the MIPS performance categories. There were not a ton, but there are some notable ones to be aware of. First and foremost, though, I want to pause here and just acknowledge the fact that we are all very much still knee-deep in the pandemic. COVID-19 has absolutely affected the way all of us live our lives. It has absolutely affected how nearly every medical clinic in the country has been able to take care of their patients. CMS recognizes again that we are still in the grips of this pandemic, and it is very difficult for clinicians, for some clinicians, to really do well in this program because they're focused so heavily on their COVID patients, which is exactly what they should be doing. If you are one of those clinicians or groups that is being severely negatively affected by COVID again this year, you can once again apply for an extreme and uncontrollable circumstances exception application. This allows you to request reweighting for any or even all of the MIPS performance categories. So you get to pick and choose. You can ask to take a pass on 1, 2, 3, or maybe all 4 MIPS performance categories this year if you are being severely affected by COVID-19. So I highly, I don't recommend that you do this just to take a pass, but I know that there are a lot of clinicians out there in practices that are really, really struggling. And so if you are one of those, and you just can't get to the MIPS performance and be watching your measures, or you're afraid that the cost category is going to be terrible for you this year because of all your COVID patients, there can be any number of reasons related to COVID or any combination of those categories that are being affected by COVID. Go ahead and put in the EUC application. If you cite COVID as the reason, for the most part, we're seeing CMS rubber stamp these with approval. You have until the end of the year to get this in, so you don't have to make that decision now. However, you can actually apply for this EUC, get approved, and then if later you decide, you know what, our data is actually pretty good, we can go ahead and submit it. Just go ahead and submit that data, and it's going to override this EUC application automatically. So definitely a good idea for folks. Although again, I wouldn't recommend it just to take a free pass. Really only do it if you are being negatively affected by COVID again this year. We did not see any changes, nor did we expect to, in the MIPS performance periods. This is the amount of data that must be submitted across the 4 categories. So similar to last year, quality is a full 12 months of data that you're submitting. Cost is also assessed over the entire calendar year. Improvement activities is a minimum 90 days, as well as promoting interoperability, minimum of 90 days of data that you must report on. All right, let's get into the different performance categories. So basics for 2021, I draw your attention to the quick start guide, the link there. That is a CMS resource. If you are new to these performance categories, excuse me, I highly recommend grabbing the quick start guides for all 4 performance categories. I think CMS has done a really good job of kind of pulling the salient information all into one resource for you to kind of get you up to speed on each of the 4 performance categories. So I've got the link to the quality category right there. As I mentioned before, it's worth 40% of your MIPS final score this year. There are well over 200 quality measures to choose from again. And while you can report on the same quality measures from year to year, just be aware that sometimes changes are made to those measures, to the specifications from one year to the next. And some measures are also removed from one year to the next. So if you're planning to use the same measures from one year to the next, just make sure that it's still a valid measure and that there were not significant changes to the measure specifications that you would want to or need to account for as you're working through those measures this year. So just like before, you're going to select and report on a minimum of 6 individual quality measures. One must be an outcome measure or a high priority measure if an outcome isn't available. If fewer than 6 measures are clinically relevant to you, report on the ones that are applicable. But I caution you that CMS needs to agree with you that there were not that minimum 6 clinically relevant measures. If you report on fewer than 6, CMS is going to take a look at what you did report and what you didn't and pass it through what they call the eligible measures applicability or EMA process. Where they kind of look at you as a clinician, decide whether there actually were other clinically relevant measures that CMS feels you could have reported on. If they do not find any of those and they agree with you that your particular specialty does not have a minimum of 6 clinically relevant measures, CMS will lower your category denominator, which is what you want there. If they do not agree with you, they're going to keep your category denominator at 60, which is the maximum 10 points per measure, and then you're going to be negatively affected by having reported fewer than 6. You can also select a specialty-specific set of measures. CMS has curated a massive list of measures that for a variety of different specialties that and some of them actually have fewer than 6 measures. If you look at that specialty measure set and see that CMS has determined that that specialty has fewer than 6 clinically relevant measures, that means that's already passed through that EMA process and you are good to go. You can, if you select that specialty measure set and it has fewer than 6, report on the ones that are there, and CMS is automatically going to lower that denominator for you. CMS wants your data. They give you bonus points for over-reporting on that. So they're going to give you 2 bonus points for additional outcome or patient experience measures, at least above that first required one anyway. You're going to get 1 point for other high priority measures. You're going to get 1 point for each measure submitted using what's called end-to-end electronic reporting method. I'll pause and just explain what that is here. So there are a few different ways that you can route your quality data to CMS. You can do it through the claims billing process. You can do it through your EHR. You can do it through a registry. You could also get that file, what's called a QRDA3 file or a quality file from your EHR, and you could upload it yourself at the portal. Some of those methods are end-to-end electronic, which means there's no human involved in the calculation of that or in the recording of that data. So claims-based reporting does not qualify for these bonus points, because that is a very manual process where you're putting quality data codes on your Medicare claims. So if you're doing claims-based reporting, you're not going to get this bonus point. However, if you are submitting through your EHR is doing it for you, or even a lot of registries would qualify for this as well, because they are electronically calculating that and submitting that data to CMS. Those are end-to-end electronic reporting. And if you are doing it by that method, you're going to get 1 point for each of the measures that are submitted via that electronic method. You're also going to get a small practice bonus of 6 points if you qualify as that small practice. This is automatically added to your quality score. A small practice is defined as 15 or fewer Medicare billing clinicians within that tax ID. And bonus points are capped at an additional 10% of the denominator. However, this is a great way to boost your quality category score. I highly recommend that you do everything you can to max out those bonus points. Data completeness, otherwise known as cherry picking, is also still something to be aware of. The data completeness, the concept there is that CMS checks to see if you or your group have submitted data on a minimum percentage of your patients that meet a reported quality measures denominator criteria. So think about the main A1C outcome measure, diabetes A1C outcome measure. CMS knows who your diabetics are that are in your panel because you have diagnosed them as such. So if you report on that particular measure, CMS is going to make sure that you have reported on a certain number of your diagnosed diabetics. For 2021, those thresholds are 70%. So you have to ensure that you are reporting on at least 70% of those patients that are in your panel. If you report on fewer than 70%, then you're going to earn 0 points for that measure. Small practices, however, who violate that data completeness threshold or don't meet that threshold are going to bottom out at 3 points for failing that data completeness. So we don't see this being an issue through EHR reporting because EHR reporting is automatically 100% data completeness. Your EHR has no mechanism to allow you to not report on certain patients that meet that denominator criteria. But other methods such as claims-based reporting, which again is that very manual process where you're adding the quality data codes to your claims. If you we see this being a much bigger issue in claims-based reporting. So you have to ensure that you're getting those quality data codes on at least 70% of the patients to whom that meet that denominator criteria. So quality is a very difficult category to work through, and that measure selection is probably one of the hardest, most time-consuming parts of all of this. It is not easy to pick the right quality measures and report them through the best method. However, the time and effort you put into that, pays off in spades. You want to use your patient population to guide that measure selection, picking clinically relevant measures if you can. Some specialties really struggle with that with the current lineup of measures available. You're going to pick what's important to you and or aligns with your practice goals. And if you're in one of the if you're working with a registry, that could be a great way to get access to some additional measures. The reason for that is registries can petition CMS to create their own custom measures and get them approved for use in the MIPS program. We call these MIPS CQMs in the program. They can be a good option for specialists who are finding limited options in the regular set of measures. So if you're in one of those specialties and you're struggling to find clinically relevant measures, I would suggest trying to find or reaching out to the professional societies that work with your specialties and see if they host or have their own registry, and then determine if they have developed some MIPS CQMs, meaning they have customized their own measures and gotten them approved. So that could be a great option for specialists. When you're looking at the data coming out of your EHR, You can't necessarily take it at face value on these measures. It's getting a little bit better. We're seeing some of these issues kind of fade a little bit, but just be aware that there are still EHR vendor issues. These are highly complex systems. I know the vendors are doing the best they can to program them correctly so that it's calculating these measures correctly. But sometimes still we see them programmed incorrectly. And so you could be doing everything you're supposed to be doing in your EHR, but because your EHR vendor has something programmed incorrectly, you're not getting appropriate numerator credit for the work you're doing in your EHR with your patient. There are also some configuration issues that could be plaguing you. Some of these quality measures, when you get them from or get them in your EHR, they don't necessarily work right out of the box. There might be some practice level or clinic level configuration that needs to happen in order for it to work properly, such as linking link codes in the background. So again, if you don't have it configured properly, you're not going to get good data out of it. And you could be doing, again, everything you're supposed to be doing, but the calculation is still failing because you didn't complete the configuration at the practice level. So I would talk with your EHR and make sure that it's working properly, that you've got it configured properly. And then, of course, data entry issues. Your staff and doctors and everybody is trying to do their best most of the time. But again, these EHRs are highly complex, and while you could train your staff appropriately to put the right data in the right fields, those skill sets drift a little bit. Mistakes are made. To err is human, right? So you could find that, again, you are doing everything properly, but then that information is not making it into the right fields in your EHR. And if it's not being recorded in the field that it's supposed to be in, then that quality measure breaks, and you're not going to get that numerator credit. So it's only after you've really addressed the vendor issues, configuration issues, and data entry issues that you can really, truly then look at that data that's coming out of your EHR for those quality measures and determine if you have quote unquote quality issues. The data submission types really matter in this program as well. Again, I already mentioned there are a bunch of different ways you can route that data to CMS. The method you choose has a massive effect on your quality category score. And I'm going to talk about that in just a moment. It's related to the benchmarks. So next slide, I'll get to that. And then the slide after that, we're going to circle back and talk again about topped out measures and topped out and capped at 7 points measures. So a lot of the quality measures are topped out. A topped out measure means that there is very little performance difference between the highest performers and the lowest performers. So like everybody's doing exceptionally well, even the lowest performer, if that happens over consecutive years, a measure gets marked as topped out, to kind of flag it as one of those. It's very hard to score really well in topped out measures. And I'll show you why in just a couple of slides. And then it gets even worse that when a topped out measure has been topped out for consecutive years, CMS then caps the max points at 7. So for the other measures, you can earn as many as 10 points per quality measure. But if it's been topped out for successive years, CMS now caps those at 7 points, meaning the best score, 100% performance on that measure, is not going to earn you 10 points anymore. It's going to earn you 7 points. And so there are some pitfalls and some bumps in the road you need to be aware of and avoid if you can. And I'm going to talk about that again in a couple slides. So first, we're going to talk about how that submission type that you choose, that submission method to get your quality data to CMS, can make a huge difference in your quality category score. There's a lot of data here. I'm going to walk you through. It's somewhat color-coded. Don't pay attention to the benchmark data that's here. This is fake data. It's from years ago. So this is just to kind of bring this concept to you. Okay, so what we have here is measure ID 110, the preventative care screening of influenza immunization. This particular measure can be scored or can be submitted via claims, via the EHR, or via your registry. So the issue is there is a different benchmark that is established for each one of those submission methods. And of course, your score that you get is based off of how your performance compares against the benchmark. So here in this fictitious example, on this measure, we have a fake clinician who scored a performance rate of 62 points. So here you can kind of follow the claims base. Here's all the math and everything. But if you look, the performance score of 62 points via the claims-based benchmark is going to put you in decile 5, which decile 5 means that you're going to score somewhere in the range of 5 to 5.9 points for this particular measure. As you do the math through the formula, we find that a performance rate of 62 is going to earn the clinician 5.96 points for that particular measure. So let's switch to EHR-based reporting. You've done nothing different. Patient care is exactly the same. The only difference here is that you have submitted that quality data through your EHR instead of the claims-based reporting. So here, that exact same performance rate of 62 puts you in decile 8. And if you do the math, we get 8.9 points for that measure, almost 3 points more than through the claims-based. And then the registry in this example is somewhere in the middle, where you get 6.64 points because you're falling into decile 6. So you multiply this 6 times over, and you can easily see how reporting through the EHR versus the claims-based reporting could have a massive difference, because you're getting, in this example anyway, an additional 3 points for each one of those measures. And really all you've done is just used a different reporting method. So if you can, you want to make sure that you're picking the best submission method that you can to maximize your score. That is not claims-based reporting. It's actually one of the most difficult methods to report on. So if you can avoid claims-based reporting, I suggest you do, though I know a lot of you are still stuck having to do that claims-based reporting due to some limitations to your EHR if you don't even have an EHR. But if you can, I suggest looking at some EHR-based or even registry-based reporting, because I think you'll find that you're going to score better in this category. All right, back to topped-out measures. Avoiding those if you can. Again, it is not easy to do. But we're going to talk about how even if they're not capped at 7 points, you really have to try to avoid these topped-out measures. So this first graphic, these are all screenshots from the 2021 quality benchmarks file. So these are this year's benchmarks. The link for this is down at the bottom of the screen. It's going to download a zip file that has some Excel spreadsheets in it. And these are snapshots from that Excel spreadsheet. So here we have a number of different measures. They are all topped out. We have them listed here, but they're not capped at 7. So you could still get 10 points for each of these measures. But look here, here's what happens with topped out measures. You actually can't score anywhere between 7 and 9.9 points on this measure. So you can still get 10 points. You can still hit decile 10 at that perfect score of 100. But if you have one tiny thing go wrong, one bad outcome, forget to cross one T, dot one I, and your performance rate now is 99.99%, you're going to actually score 6.9 points for that. You cannot score 7, 8, or 9 points on this measure. Same thing here on this one. One tiny little mistake and you're dropping all the way down to 5.9 points. So with these missing deciles, it makes it really, really hard to do well using topped-out measures, unless, of course, you're still able to get that perfect performance at 100. But then it gets even a little more complicated, as if that wasn't complicated enough, right? So although not yet topped out, some scoring options or deciles are already missing. So here we have some examples in the second graphic here at the bottom, where these measures are not topped out. So of course they're not capped at 7 yet, but look, we're already missing deciles. This one actually surprises me. Measure 114 submitted through Part B claims. To me, this is already acting like a fully topped out measure, because you're missing 4, 5, 6, 7, 8, and 9 deciles there. So one tiny little mistake and you're dropping all the way back to that 3.9 points for not getting that perfect 100. So I suspect next year we'll probably see this measure, 141, listed as a topped-out measure. And honestly, I'm not sure why it's not already, because we're already missing so many of those decile scores. So it's difficult to do. A lot of folks can't avoid using top-down measures because you're looking for things that are clinically relevant. However, if you can avoid top-down measures, I definitely suggest that you do. All right, cost performance category. Again, the quick start guide there. It's worth 20% of your MIPS final score. We will see this raise all the way to 30% as of next year. That is mandated via the macro rule. There's no reporting requirement, though. The data is pulled from all of your administrative claims. There are 20 in total measures that you could be scored on. No clinician that I'm aware of ever gets scored on all 20 of them, however. We have the Medicare Spending Per Beneficiary Clinician, or MSPBC measure, the TPCC, the Total Per Capita Cost measure, and then the same 18 episode-based measures that we had last year are again being used for this year. So no new measures added for this year, but just be aware that some of the specifications have changed, especially relative to telehealth. So just be aware of what those changes might be and how they might affect your score this year. In order to be scored on a cost measure, you have to have enough attributed cases to meet or exceed the case minimum for that cost measure. So what happens here is if one or more of those cost measures apply to you, then they will constitute the total cost category score. So you could get a cost category score off of just one of these 20 measures. Let's say just the MSPBC applies to you, or just the TPCC applies to you, then that score on that measure is going to constitute your entire cost category score. If there are 3 that apply to you, then the performance on all 3 of those will be used to create your score. If no cost measures can be applied to the clinician or the group, then that 20% category weight gets reallocated or reweighted over to the quality performance category. So if no cost measures apply to you and you are participating in the quality category, then quality is not worth 40 points, it's going to be worth 60 points or 60% of your MIPS final score, where the cost would be only 0. Here we have the description of the 2 kind of main or big cost measures, the MSPBC and the TPCC. I'm not going to go through this at all. I just have this here for your reference if you want to grab the slides and get some more information. Here are the 18 episode-based measures that are being used for this year. Again, I'm not going to get into the weeds here talking about any of these cost measures. If you want some more information on these cost measures, I highly recommend grabbing the slide deck and clicking on that link at the bottom of your screen. It's going to download a zip file from CMS that has a wealth of information across all 20 of those cost measures. So here, I usually pause and talk about how facility-based scoring will be or could be used to help you in your quality and cost categories. However, we got a surprise earlier this month that facility-based scoring is actually being suspended and is not available for performance year 2021. This is sort of a devastating blow. A lot of clinicians need this facility-based scoring option, which in prior years has allowed their quality and cost category scores to be determined based on the hospital VBP program, the hospital to whom they are affiliated with or providing most of their care at. This has been a great thing for these facility-based clinicians, and I'm so sad to see that CMS had to suspend this option for this calendar year due to COVID. So what's happened here is that CMS they've had to suspend some of the measures that get used to determine the hospital VBP score. It's that score that was feeding into the facility-based scoring for the quality and cost categories. So they are not going to be calculating a hospital VBP score for any hospitals this year. And so therefore, there's no facility-based scoring for 2021. So what this means is that you have a couple of options. You either need to submit your own quality measure data from your clinic, which I know is problematic. That's why you're a facility-based clinician, because so much of your work is being done at the hospital and you're not able to generate good data at the clinic level to submit for MIPS. So you have that option. You can submit that quality data and hopefully you're going to get a good enough score. I would suggest also considering submitting an extreme and uncontrollable circumstances exception application. If you are one of these facility-based clinicians who was planning to use facility-based scoring again this year, but now can't, you could consider, instead of taking that really low score that you're going to be able to generate at the clinic level, I would consider submitting the EUC to take a pass on quality and possibly cost performance categories so that you're not negatively affected by the fact that CMS is not going to use facility-based scoring this year. All right, improvement activities, quick start guide, it's worth 15% of your score. There's a total of 105 improvement activities that you can use for this year. When you're selecting an activity, it's sort of the honor system. You're just attesting yes to the fact that you had it implemented for a minimum of 90 continuous days in this calendar year. Each activity of those, each of those 105 activities is weighted, and so it earns points based on that weight. There are medium weight and high weight activities. The medium weight are worth 10 points, high weight are worth 20 points, and you max out the category, meaning you get the full 15% or 15 points to your MIPS final score when you've earned 40 points within the category. So note that small practices, non-patient facing clinicians, clinicians located in the rural or health professional shortage areas receive double weighting on these points. Therefore, if you're one of those small practices, let's say, or that non-patient facing clinician, each of these improvement activities, the medium ones would be worth 20 points and high weight would be worth 40 points. So therefore, a small practice, let's say, would only need to report on a single high weight activity to max out this category and get the full 15 points to your MIPS final score. They've modified a couple of the existing improvement activities. They've removed one of the improvement activities that was available last year, but is not available this year. And while you can use the same improvement activities from year to year, just review the changes that were made, or if there were changes that were made to your improvement activity, and make sure that it's still valid for use this year. Don't automatically assume that your improvement activities are the same or are still available this year. I also highly recommend that you grab the data validation file from CMS. Again, that link is on your screen there, to get some additional vital information on your chosen activities, and especially, probably most importantly, that CMS recommended audit documentation. So this is one of those categories where the data is, you're submitting it sort of on the honor system. When you go to a test, you're telling CMS that you had this improvement activity or activities implemented for that minimum 90 days. You're not submitting any data to CMS at that time to validate that or to prove that. But CMS could come back and audit you up to 6 years from now. And if they audit you, they're going to ask for proof on that you did have that improvement activity implemented like you said you did. This data validation file has some really helpful tips embedded in it for what CMS is going to be looking for or asking for if and when you do get audited. So I highly recommend you grab that file and make sure that you have that documentation stored somewhere today, because I guarantee 6 years from now, you're not going to be able to find it and you're going to fail your audit, and you don't want to do that. And a group or virtual group can attest to an improvement activity when at least 50% of the clinicians in the tax ID perform the same activity during any continuous 90-day period within the same performance year. So if you're in a group, all or 100% of the clinicians within that group don't necessarily have to have had the same improvement activity implemented. As long as at least half of them have done it, then the whole group gets that credit. And it does not have to be the same continuous 90-day period that each of those at least 50% had it done, as long as at least 50% had it for any continuous 90 days within that performance year. Again, doesn't have to be the same 90-day period. PI category, promoting interoperability. Quick start guide there. I highly recommend you grab it if you're new to this category. 25% of your MIPS final score. You do have to use your 2015 certified EHR technology, or CERT. There's a link to what's called the Chapel site if you want to determine whether your EHR has that 2015 certification. You could also just reach out to your vendor and request that information as well. Performance is based at the individual measure level. There are 4 objectives with up to 7 measures within them to report on. We have the e-prescribing objective, health information exchange, provider to patient exchange, and public health and clinical data exchange. I'm not going to get into all of the measures that are within them, those 4 objectives. But if you want some measure specifications, again, I have hyperlinked on your slide there at the very bottom, the 2021 PI measure specifications. So we did see a couple of changes within the PI category in those measures. One was on the query of prescription drug monitoring program, or PDMP measure. It is still just a bonus measure. You do not have to report on it. Last year, if you said yes to the fact that you have done this, you would get 5 bonus points. They have upped that this year to 10 bonus points. Again, you do not have to have the PDMP integrated into your EHR to claim that credit. In the state of Michigan, anyway, if you're writing a script for a controlled substance, by law, you have to check MAPS, or our state's PDMP, prior to writing that script. You can do that by just logging into the MAPS website and double checking the information there against your patient. If you have done that, you can claim, if you've done that on a single clinician, or a single patient, a single prescription, you can claim those 10 points. They've also changed the name of the support electronic referral loops by receiving and incorporating health information measure, which is a mouthful. I've replaced the word incorporating with reconciling to better reflect the action you're taking through that measure. This third change is an interesting one, potentially a very helpful one for you as well. They have instituted a new optional health information exchange, or bidirectional measure. So here you have an option. If you're reporting in PI, you can either report the 2 existing measures. If you're familiar with that, there's a sending measure and a receiving measure. You could report on each of those individually, just like you've done in the past, and your performance relative to your numerators and denominators would be converted into your performance rate. You'd get as many as 20 points for each of those measures. You could actually flip over to this new bidirectional measure and not report on the 2 existing HIE measures, and only report on this one bidirectional measure. And this one is reported by attestation with a yes or no. So if you attest yes to this, you're going to get all 40 points. If you select no, of course, I don't know why you do that, but you're not going to get those 40 points. But I just caution you here that if you look at the 3 statements that you're saying yes to, and just if you're going to flip over and use this bidirectional measure, just make sure that these are truly yes for you, and make sure that you have some sort of documentation to prove that you were legally able to say yes to each of these 3 statements. And that might require you to go to your health information exchange, or HIE, and have them draft some sort of letter, perhaps, to say that yes, this client or this clinician did have all of this capability enabled during the performance year. So could be a good way to ensure that you get all 40 points. But again, just make sure that you have that documentation if you're going to use this new bidirectional measure, so that you don't fail an audit down the road because you can't prove that you could say yes to these. PI performance category reweighting. So there are a couple of different options for reweighting, and by reweighting I mean that the weight for that performance category would shift over to the quality category. There is automatic reweighting, so that's applied without any action from you. If you are any one of these EC types or special statuses that are listed on your screen there, CMS is already not expecting PI data from you. However, if you do submit PI data, it's going to override this automatic reweighting, and it's going to put the weight back on the PI category. If you do not submit PI data, then that reweighting remains in place, making your quality category worth 65%. There's also application-based reweighting. And again, you have to apply for this. But if you do, CMS could approve it and then do that same reweighting where they push the 25% that would normally be in the PI category over to quality. So there's a few different reasons you could apply for this application-based reweighting. Probably the most popular one is the small practice. So if you are in a tax ID with 15 or fewer Medicare billing clinicians, CMS sees you as a small practice, and you can put in an application to take a pass on the PI category, and they're going to automatically rubber stamp that. There's some other reasons there as well that might apply to you, and you might want to take a pass on PI for this year. But again, you have to put in that application. I've got a link to the application on your screen there. And again, you have until the end of the year to get that in. And it works the same as the EUC application, where you could put in that application, but then at the end of the year, you might decide, oh, you know what, we actually did pretty well in PI. We were able to overcome our barriers and our struggles, and we're doing really well. So if you're in that boat and you want to change your mind, just submit that PI data. If CMS gets that PI data on somebody who has been approved for that application-based reweighting, they're just going to go ahead and score it and override that application. 2021 performance thresholds and payment adjustments. So last year, the minimum performance threshold was 45 points. This year, as I mentioned in the first couple of slides there, it is a minimum of 60 points to avoid a penalty. There were no changes to the additional performance threshold for those exceptional performers. That is at 85 points there, which means if you are at least 85 points, you're going to get some additional monies or some additional adjustment added to your Medicare reimbursement rate. And there's no change in the payment adjustment from last year to this year either, meaning you could get penalized as much as 9% on your Medicare reimbursements. We should, by the books, see positive adjustments of positive 9 or even above that. However, we're not going to see that again this year. Similar as we've seen every year, we just don't have enough folks getting penalized right now to pay out those top end reimbursements, those big ones. It's because the program has budget neutrality baked right into it. So the positive MIPS payment adjustments are being paid by the negative adjustments. The folks that are not hitting that performance threshold and are getting penalized are the ones funding those positive adjustments. So we need enough folks getting penalized in this program to really see those big adjustments, those positive 9 or even above adjustments, because they've got something built in called the scaling factor. So and really we're not seeing the scaling factor scale up on those top end adjustments right now. It's having a negative effect on this, where I think last year the best score was like 2% again. So hopefully this changes a little bit, but here's kind of graphically what we're dealing with here. So again, for this year, we've got that performance rate of 60 points. You want to at least be right here. If you are below that 60 points, you're going to get hit with a negative adjustment. Your reimbursement rate is going to be lowered. And those monies are actually going to get passed up here to the folks that are above that 60%. And then we have that additional performance threshold of 85 points. And really, this is where you want to be shooting for. You want to be at least 85 and above, because this is where we're seeing almost all of the payment adjustments. Any positive adjustments are really at this point really only starting right here. And it's because we don't have enough folks down in this range to be giving any of the folks in this range any positive monies. That scaling factor is essentially wiping out any positive adjustments until you get to that exceptional performance threshold. And that is because the exceptional performance threshold is paid out in a different bank. There are separate monies that are being set aside to pay out those exceptional performers. that is not affected by that scaling factor. So here's just a graphic of kind of, what you can expect based on where you fall relative to that 60-point neutral payment adjustment threshold. And note that the performance threshold has incrementally increased each program year. We're going to continue to see that happen for the foreseeable future. For the 2022 program year, so again, looking ahead to next year, that performance threshold, the one in the green box there, is going to be based on the mean or median of the final scores for all MIPS eligible clinicians in a previous year. So up to this point, up to 2021, CMS has been able to just name whatever minimum threshold they wanted. It's in the macro legislation that as of next year, they have to start basing that minimum threshold on the mean or median of the final scores from previous years. So that means next year, we are going to likely see the 2022 minimum performance threshold be somewhere in the range of 70 to 85 points. And in fact, we have that proposed rule out right now. We're waiting for a final rule, but CMS has proposed that the 2022 performance rate is going to be 75 points. So what that means is that as of next year, participants are going to need to achieve scores which were previously considered exceptional performance just to avoid a significant Medicare penalty. So I highly suggest, I mentioned this before, that don't take a free pass if you don't have to, just to avoid the work, because you need to be working on your quality measures. You need to be working on those workflows. You need to be paying close attention to this MIPS program, because if you aren't achieving those really high scores as of this year, next year, that performance is going to mean you get penalized, and you want to make sure you're not getting penalized in this program. All right, we're going to flip gears now and talk for a little bit about the other track. We're moving away from the MIPS track and moving into the other track, the alternative payment models. So an APM, or alternative payment model, is this generic term that CMS came up with that describes that payment model in which providers are taking responsibility for the cost and quality of care and receiving payments that are relative to that care. The most common type of APM is an ACO, but there are several other types of APMs out there as well. And the QPP doesn't change how any particular APM pays for their care or rewards that value. It's going to add some additional incentives on top of that contract you have with your APM. And then APM participants also participating in MIPS may receive favorable scoring under certain MIPS performance categories. Remember way back on that first slide where I talked about where there's almost that third track that bridges the gap between the two kind of main tracks? That's what that bullet is referencing right there. I'm going to get a little deeper into that in just a moment. And then some APMs are deemed advanced APMs. They're at the very top of the pyramid. And that's really CMS's goal. So these advanced APMs are those APMs out there that have the greatest risks, but also offer the potential for the greatest rewards. That's actually QPP's goal, is to get as many of you into these advanced APMs as possible. Right now, the vast majority of QPP participants are still in the MIPS track, but just note that CMS is applying pressure and urging you and giving you better incentives to make that flip, to join the other track and get into one of these advanced APMs. That's where CMS wants to see you eventually in this program. But it's not enough to just be in the advanced APM. You also need to achieve what's called QP status, or qualifying APM participant status. I've got a link to the quick start guide here. If you're not familiar with what a QP is or how it's calculated, grab that quick start guide. It's going to give you some great information. But in essence, what we're talking about here is a qualifying APM, or a QP, is one that meets increasing thresholds for the percentage of charges from attributed beneficiaries that pass through the APM's payment methodology. So each one of these APMs has beneficiaries attributed to it. You need to make sure that those attributed beneficiaries are only seeking care from within your APM, within your ACO. if there's too much leakage outside of that ACO, you could fail to meet QP status. And then a lot of the benefits of being in an advanced APM are gone. And I'll talk about what that means in just a moment. So an individual EC in a qualifying APM is a qualifying APM participant, or QP. And the best thing about being a QP is that you're not required to report to MIPS. You get to avoid all of that mess we just talked about for the past hour. Medicare Shared Savings Program ACOs, QP status is awarded to all of the advanced APM participants collectively or to none, as the case may be. So either the entire MSSP ACO hits QP status or none of the participants in that ACO get it. They calculate QP status using the better of these two methods. CMS might use the payment amount method, and I've got what that means right there, or the patient count method. And there are the thresholds listed there for what those minimum thresholds are to get that QP status. CMS is going to calculate both ways for that APM or for that participant. And again, just like we've seen elsewhere in the program, they're going to award you with the better of those two methods or those two scores. You can check your APM participation as well as whether or not you have QP status with the participation status lookup tool, the link there on your screen. It's the same one you go to in order to see if you are exceeding that low volume threshold for MIPS participation. It's also going to give you some great information on whether CMS recognizes that you are in some type of APM, whether it's that advanced APM, and then whether you have that QP status as well. So here we have 2021. We are at 50% and 35%. We were going to see these thresholds skyrocket, but there was some legislation that went in late last year that kind of froze these down at the lower levels, thankfully, for this year and next year. So we'll have to wait and see. I suspect, excuse me, as of 2023, we'll see these QP thresholds go up quite a bit. So what if you're in one of these advanced APMs, but you don't hit QP status? So if QP status is not met, CMS is going to also assess you against some slightly lower minimum thresholds. If you shave off 10% off of these thresholds we just showed you, you could be considered a partially qualifying APM participant, or PQP. If a PQP chooses to stay in the advanced APM track, you're not going to receive any of the APM bonuses, which I'll talk about on the next slide. But you're also not subject to MIPS. So there's no data submission, no financial adjustments whatsoever as a PQP, if you choose to stay within the advanced APM track. However, these PQPs actually have a choice. You could decide to opt in and participate in MIPS as a PQP, in which case all of the MIPS rules would apply to you as well as the MIPS incentives. So if the APM participant is not a QP or a PQP, then you must participate in MIPS if you are exceeding that low volume threshold. So if you're in that advanced APM, but you don't hit QP or PQP status, CMS is essentially going to look at you as a MIPS APM participant. And then that's that bridging the gap track that we talked about early on. So one of the incentives for being a QP in the advanced APM are pretty good. So the model design, the advanced APMs have shared savings, flexible payment bundles, other desirable features. None of that's affected by the QPP. However, for this year and still next year, if you are a QP in the advanced APM, you get a 5% lump sum bonus payment that's made directly to the eligible clinician who's participating with that advanced APM. There is legislation out there. I haven't heard anything lately on it, but they're looking to extend that beyond 2022. But as of right now, you could still get that 5% lump sum bonus for this program year and next program year. And hopefully CMS works with Congress to get that extended a little bit more, but that remains to be seen. You also get higher reimbursement updates for being in the advanced APM as a QP. So right now, the physician fee schedule has been locked in place where it's not getting any annual updates. The only way to get a better reimbursement rate is to perform well in the MIPS track of the QPP. But as of 2026, we're going to start seeing annual baseline payment updates made to the physician fee schedule. And it's going to be higher for the folks that are in these advanced APMs. So if you're in the advanced APM, your Medicare reimbursement rate is automatically going to tick up 0.75% each year. And then the regular MIPS participants, it's only going to tick up by 0.25%. So it's a great reason to join one of these advanced APMs as well. And probably one of the best reasons to be in these advanced APMs is that you avoid the MIPS track completely, as long as you are that QP. All right, MIPS APMs, these non-advanced APMs that are out there, which is actually the majority of Medicare's ACOs still, are not advanced. And again, this is that bridging the gap step, or that path that is between the regular MIPS track and the advanced APM track. So the advanced APM benefits don't apply. So you still, if you're in one of these MIPS APMs, again, a non-advanced APM, you still have to participate in MIPS to receive any favorable payment adjustments. The APM entity participates as a single large group with all that data aggregated to the APM entity level. All MIPS APM participants receive the same MIPS final score relative to that APM, and then they all get the same payment adjustment as well. You don't qualify for that 5% advanced APM bonus payment, and you're not eligible for that higher baseline annual update that I just talked about starting in 2026. However, there are some fantastic benefits for being in these MIPS APMs, the least of which is maybe that strength in numbers. So we see these MIPS APMs performing exceptionally well because there are so many clinicians in these, and the rising tide raises all boats. These MIPS APMs are usually doing exceptionally well, and you might find that they're going to outperform you at the clinic level because of that strength in numbers. In 2021, the MIPS APMs received full credit in the improvement activities performance category. Another great benefit, you don't have to worry about the improvement activities category. Also, cost is already assessed as part of the APM, so there's no additional MIPS cost category considerations. You, of course, get the shared savings or whatever other APM-specific rewards are built into that. Again, the QPP is not going to change that contract with CMS or with your ACO in terms of those financial benefits. It's going to just add some additional ones on top of it. And then you're eligible for those annual MIPS bonuses, those incentives. If your ACO is performing exceptionally well, and they're getting way above and they're getting into that exceptional performance bucket, you're going to continue to take advantage of that, which is going to continue to boost your Medicare reimbursement rate. We have a good but somewhat complicated option that's come to us this year as well. It's called the APM Performance Pathway, or APP. So really what this does is it doesn't lock you in to that your ACO's group score. It actually opens things up and gives you some additional options to really participate in the quality payment program, or the MIPS track, however you would like to, even if you're in one of these ACOs. So it's essentially the first MVP or MIPS value pathway that CMS is bringing to us. We'll see the MIPS value pathway or MVP program come to us more in a couple of years. But essentially, that's what we're dealing with here with the APP. So it's available to all the MIPS APM participants. So if you're in any type of APM or any type of ACO, this is available to you. It is required this year for any of the MSP ACOs, the Medicare Shared Savings Program ACOs. So all MIPS eligible clinicians, including those in the MIPS APM, can now participate in MIPS as an individual clinician, a group, or the APM entity. Previously, if you were in one of these MIPS APMs, you only had the option to participate at the APM entity level. Now, you can also participate as an individual clinician or as a group. We see the category weights and how they shift if you're participating under the APP, where the quality is increased to 50, cost is 0, PI is 30, and IA is 20%. So really what the APP does is it significantly alters the quality category component for these APMs significantly reduces the number of measures that are being reported on. So it really lifts that reporting burden off of these MIPS APMs. We have the caps for ACOs measure, which has been used in the past, is being eliminated, but now there's the caps for MIPS, which is instead of an ACO level survey, it's now a clinic level survey. There are only 3 clinical quality measures to calculate and submit on. The quality ID 1, the diabetes hemoglobin A1C poor control measure, quality ID 134, preventative care and screening for depression and follow-up, and then quality ID 236, the controlling high blood pressure. Those are the only ECQMs that are being used here, or MIPS EQMs that are being used here. And then there's 2 new claims-based population health measures that are being added as well. So we only have 6 measures that are being used for the quality category under the APP, which is a significant reduction from what we had before. So again, it is mandatory for the MSSP ACOs to use the APP this year, but they can opt to use the CMS web interface and those corresponding measures for 1 more year if they would like to. Making this change to the APP is going to be problematic. It's a little difficult. And so CMS has taken COVID into consideration and have decided that they want to give you that option to still use the old method of reporting for another year if you need it, although you can flip over to using the APP measures as well. Again, you see the total number of ACO quality measures has reduced from 23 measures down to 6. And the number of measures the ACO itself was required to actively report used to be 10 under the old method, and that's down to 3, those 3 ECQMs we just talked about. So significant reduction in burden. So you've got those enhanced MIPS reporting options. And then the EUC, the Extreme and Uncontrollable Circumstances application is now available at the ACO level as well as of last year. So again, what this has done is it's really given you the options. So you're not locked into that APP score, APM score, that APM entity score. You can still get that score, and you will get that score because your ACO is still going to participate at that group level. But it really opens up the options for you now, where you can report outside of your ACO or in addition to your ACO. And you can submit MIPS at the individual or group level just for your TIN. And then CMS is going to look at the score that your ACO or your APM has generated for you. And then they're going to look at the data that you have submitted at the group level. And again, just like we see everywhere else, they're going to give you the better of those 2 scores. So this opens up a bunch of questions for these APMs and the folks within them to make some decisions now going forward. The most difficult one, I think, is for reporting at the ACO level. How will clinical quality measure data be collected and calculated? I think this is probably the most difficult thing for these ACOs to consider now, especially when the CMS web interface goes away. And they're needing to collect the electronic clinical quality measure information across all of their disparate EHRs and TINs. Somehow these ACOs are going to have to glue all that information together, because you can't submit individually to get that group score for quality measures. The ACOs are going to have to find a way to consolidate all of those ECQMs across all of their participants into a single data set. And right now there are not great options, and definitely not cheap options to make that happen. Should ACOs have groups or TINs submit the APP directly? Will the ACO organize a caps for MIPS option to leverage some better pricing? I'd love to see these ACOs work with the caps for MIPS vendors to offer their members a reduced rate for using that single vendor. Hopefully the ACOs can manage that to lower your costs a little bit. Which individuals, groups, TINs should also submit traditional MIPS because they can earn a higher score or earn that higher incentive than the ACO score? And will some ACO participants want to submit traditional MIPS to control their own fate? So again, you are no longer relegated to accepting the final MIPS score that your ACO can generate for you. Again, as I mentioned before, a lot of times that's a great score. I'm seeing ACOs getting the full 100 as well, but not all of them are there. And so you're really going to want to take a look at it this year and in future years and decide whether you can do better than your ACO by reporting on your own and control your own fate in this program. All right, getting to the very end of our slides, one thing I wanted to talk about is our free technical assistance. If you are at all struggling in this program this year, please don't struggle on your own. CMS is still funding us to be out there helping you. It's what brings me to you today. We would love to work with you. We love answering your questions. We love helping you get the best MIPS final score you possibly can. You're going to click the QPPresourcecenter.org link at the bottom of your screen. And if you are a small practice, you can join us for free and get all of our help. It's going to tap you into a team of my awesome colleagues that are also subject matter experts in this program. And you can hammer them with every question you can possibly come up with. We're going to work tirelessly to make sure that you get the best MIPS final score you can. And that is all for free. However, it's only available until the middle of February. Unfortunately, unless something changes at CMS, our support contract and the contracts that are for organizations like Altarum and all of our partners that are across the entire country, our contracts all expire as of February 15th of next year. We wish that wasn't the case. We would love to continue to assist you beyond February 15th of 2022. We are sincerely hoping CMS does something to extend our contracts. But as of right now, the QPP Resource Center and all of our free assistance goes away about halfway through the data submission period for next year. So again, we're doing everything we can to get CMS to extend contracts and keep the QPP SIRS program going longer. But just be warned that things are going away. But that said, you can still get to us now. So we are here to help you at least through February 15th. If you're struggling in this program, don't do it alone. Let us help you. I am certain we can assist you. One of the best things that joining with us does for you as that small practice is it also gives you access to MIPScast. MIPScast is our own proprietary scoring tool. Think of it as a sandbox. We know exactly how CMS is going to process your data, and we've built a system to mimic the way that CMS scores your data. It allows you to import or enter your data into MIPScast, and it's going to calculate that score. And it's going to tell you exactly that if you submitted that data set to CMS, here's what your final score is going to be. You can give us as much data as you want all year long, and we're going to help you determine what that best data set is using the MIPScast tool. MIPScast is also a CMS qualified registry. What that means is we can submit your data on your behalf. You could work with us throughout the year, and again, this is all free for those small practices. You can give us your data. We're going to work with you at it. You can give us 100 data sets if you'd like to, and we're going to work with you to determine which of those data sets is the best data that's going to get you the best final score. It's going to allow you to report on different quality measures. You can examine group reporting versus individual reporting. It is a sandbox that has all of the options built into it. We can help you identify what that best MIPS final score is with your data, and then we will flag it with your permission, and we will submit it to CMS on your behalf. Again, we're not going to do that without you. There's some additional steps, so we're not just going to randomly report your data. There's a whole process that goes into it. But if you would like, and you do not have to, but if you would like, we can submit that data on your behalf. However, the end of our contract with CMS affects that as well. This year, because our contract ends as of February 15th, that is the deadline to get your MIPScast data submitted and get it into us. We actually have had to back up that another month. So really, and again, really wish this wasn't the case. We're really hoping CMS comes through with a contract extension for us so we can continue helping you through the full data submission process. But as of right now, if you are planning to use MIPScast to report your data, you have to have that data in and identified by January 15th, which is only 2 weeks into that submission data period, which we know is problematic. So get working with us now, get a plan in place. We want to make sure that if you are going to use MIPSCast as a small practice and use us to submit that data for you for free, that we are able to get that data identified and lined up to submit, that we can do it before our contract ends with CMS. As of February 16th, we cannot do it for free anymore. We will still be available for a small fee to assist you if for some reason you are not able to get your MIPSCast data in and identified as the data you want us to submit on your behalf by the 15th of July. I'm sorry, of January. So it's not like we're going to disappear as of February 16th, but we will no longer, unless something changes, we will no longer be able to do all of that for free for you. You'll have to work with us for a small fee instead. But again, plug into your QPP reps right now, your QPP advisors, my colleagues. Get to them now, get a plan in place, make sure that you are on track to get your data submitted in time so that we can make sure that we are doing everything we can to get you that best MIPS final score, and we get it to CMS in time. So with that, I thank you all for attending today and watching this webinar. If you have any questions for us, do not hesitate to reach out. You can get to us through the QPP Resource Center and tap into all of my awesome colleagues. You can email the qppinfo@altarum.org inbox with your question. You can reach out to me personally as well. I also love answering your questions. You've got my email address on your screen. You've got my desk number on your screen. If there is anything that we can assist you with relative to the quality payment program, do not hesitate to reach out. It is why we are here. There's no reason to struggle alone. I guarantee we can help you with whatever problem you're having. With that, thank you so much. I hope you enjoy the rest of your day, and I look forward to seeing you on future broadcasts.